Catherine Cole here. She's going to be talking to us about blood transfusions and red cell exchange in sickle cell disease from people from different cultural groups. So I'm looking forward to the PowerPoint presentation to learn more things about this. So thank you, Catherine, whenever you're ready.
Thank you very much, and good evening and good morning and good afternoon. I think we're everywhere. Okay, so here's Joe's paper, and these slides are all available, so you can find the references if you like. The second paper is one from a series that's published in Blood called How I Treat, and they're all excellent. And I learnt a lot reading this paper in particular. So in transfusion for patients with sickle cell disease, we have to remember that it's not necessarily our first line of therapy. That remains hydroxyurea. But for many years, the only other treatment we've had to help patients is blood transfusion. And a simple transfusion, just giving blood, will increase the oxygen carrying capacity. But we have to remember that if we give too much blood, we might make the blood too thick or viscous. And that can be a problem and actually increase the risk of things like stroke. So we have a target hemoglobin that we don't like to go above. We can get around that a bit if we do an exchange transfusion where we take out the sickle hemoglobin in the patient's own blood and replace it with blood bank blood. But simple transfusion remains the most common method of transfusion used in chronic transfusion programs, particularly in children. But of course, it comes at the cost of iron overload. And you can see here some comparisons between various types of transfusions. A simple transfusion, doing a manual exchange, which many of us can do very easily. It doesn't require any specialized equipment. Or an automated red cell exchange, which does require specialist equipment and staff training, but is the best way of making sure that we can keep control of that hemoglobin S% in the blood and not lead to iron overload. But it usually requires either the ability to put in the specialized catheters that we require, intravenous catheters at each occasion, or to have an implanted central access device. Now, there are some well-known emergency indications for transfusion, including sometimes acute anemia if it's very severe. In stroke, we would go straight to an exchange. Usually for pain crises, there's no need for a transfusion, neither is there in an uncomplicated chest syndrome. And actually, I saw today that there's an article on this in last month's British Journal of Haematology for anyone interested. And then there are other reasons why we might quickly go to an exchange transfusion. For a long-term transfusion, it's mostly for patients who have had a stroke or who is at risk of having a stroke. And we find this out by doing an ultrasound of blood flow through the arteries in the brain, a so-called transcranial Doppler. And this has been extremely a good way of telling who's at risk of stroke, and putting them on a long-term transfusion program was the best way of preventing stroke. And now you can see there are other non-neurologic indications for going on such a program. And mostly it's if other treatments haven't worked, particularly if hydroxyurea is ineffective. Pregnancy is a special situation. And patients who are thinking of becoming pregnant are often advised, quite rightly, to come off their hydroxyurea. And for patients who are on hydroxyurea with a past history of many complications, that's usually an indication to switch over to a transfusion program during pregnancy. And that may be simple transfusions, or it might be red cell exchange. And you can see there are many things that can happen during a pregnancy which make it a particularly tricky time and best managed in a tertiary centre by experts in both the management of pregnancy and sickle cell disease. Now, the risks of chronic transfusion, as most of us know, include iron overload, as I've mentioned. We're always worried about transfusion-transmitted infection, although fortunately, with our very safe blood supplies in most of the first world, this is exceedingly rare. And I'm going to talk a lot today instead about alloantibodies, particularly since that's my concern in my role at Lifeblood. So transfusions can be life-saving in sickle cell disease, but antibodies can develop against the red cells that we give, resulting in what we call a delayed hemolytic transfusion reaction, where the hemoglobin might initially increase following the transfusion, but falls down very quickly, and the cells don't last as long as we predict they should. And having one of these antibodies can make subsequent transfusions more difficult. Now, often it can occur because we test for antibodies when we do the cross-match, the group and screen before a transfusion, and the screen for antibodies can in fact be negative, but then the antibodies rebound, a so-called anamnestic reaction, once the patient is exposed to these red cells in the transfusion. And often those red cells are completely destroyed by the patient's immune system or complement activation, and so that we can't actually even find any antibodies. And in the severest cases, this might lead to a syndrome called hyperhemolysis, where not only the transfused cells are destroyed by the antibody, but even the patient's own red cells, and this can be very difficult to treat, and it can even be fatal in some patients. And often giving transfusions in this setting can make the patient more unwell. Now, the incidence of severe delayed transfusion reactions can be as high as about 15% if we only match for our ABO and rhesus D matching. So that's the blood group as we think of it. So I'm O rhesus D positive, O positive. But if we match for more than that, if we look at the other rhesus other than D, which is big C, big E, little c and little e, as well as Kell, then we can reduce this risk of a transfusion reaction. And a delayed transfusion reaction, hemoglobin not staying up as long as possible, sounds fairly benign, but in fact, in a large study, it was the cause of nearly 5% of all deaths in patients with sickle cell diseases. And these numbers are probably higher than I've quoted because the reactions may in fact be misdiagnosed as a simple vaso-occlusive episode. So as we now know, there's many more than just what ABO group we are and whether we're rhesus D positive or negative. In fact, there are 41 different blood group systems now described with over 350 different types altogether. So how are we going to prevent this alloimmunization from happening? Well, it is difficult in patients with sickle cell disease because big C, big E, Duffy A, KID and S are much more common in people of European descent who are primarily our donors in Australia, whereas our patients, of course, with sickle cell disease are often African in origin. And we know that the more transfusions a patient has, the more likely they are to develop alloimmunization. And we also know that the very inflammatory nature of the sickle cell disease itself during a crisis can make this worse. So that's one of the reasons why we don't recommend transfusing in a simple crisis. We know that this can actually increase the risk of immunization. So for many years now, it's been standard to match not only for your ABO group and whether you're positive or negative, but also for these other rhesus groups and Kell. But we know that individuals of African descent have very unusual rhesus types compared with those of our substantially Caucasian donor population, and can develop antibodies even when we don't predict it. And one study of children showed that matching, as we do now, nearly 50% of the chronically transfused patients and over 10% of those getting episodic transfusions became immunized. And often this is with these partial group Ds, big C or little e. And we know that we really need to be very careful about using units that are negative for those antigens in our patients. And in order to do that, we need a lot more molecular techniques to actually work out what the rhesus subtyping is. And we also know that if we can match as well for Duffy and KID and the S groups, we can further reduce this alloimmunization. And if you've had a transfusion recently or seen a bag of blood, you may notice that in fact, many more of them have this extensive phenotyping And since 2006, we've been phenotyping for extensive rhesus and KEL on all new donors, and we've now caught up to 100% of all our donors. And 5% of donations a week undergo this extensive typing, but it's not just a random selection. We're really trying to pick some of our donors who may be of use for our patients who are not similar to the regular Caucasian donors, so born overseas and particular blood group types. It is a challenging situation because we find that there are some very, very rare blood groups that happen in our African populations, and blood units for these to match these groups are really in short supply. And so we really need to think hard in a patient with one of these rare blood types, whether we need to transfuse at all, and be very careful about the transfusion not resulting in immunisation, because once the patient is immunised, it's very hard to get blood for them. There are frozen units that are kept all over the world, and we have very good collaboration where we share blood with other units everywhere. And we are actively recruiting donors of African descent. And I think last year I spoke to the group and suggested getting family, friends, anyone you know to come in and be a donor. And as you can see, we've discovered some really rare phenotypes since we've been doing this at Lifeblood. So what happens in a patient who is alloimmunized for with one of these rare blood types? Well, they're really a bit stuck, and we might need to go back to think about alternative treatments such as hydroxyurea or transplant. If you undergo a bone marrow transplant, however, you need transfusion support to get through it, and that may mean trying to get hold of enough units overseas to get the patient through the transplant. And that can be very difficult. And of course, we're really holding our breath, hoping that gene therapy trials will help cure our patients in the future. And this will happen, but at the moment, it's rare and expensive. But wait a minute. On that last slide, I said alternative treatment should be considered, such as hydroxyurea, and yet all of these patients should be on hydroxyurea. Because remember, the slide I said at the beginning was that the mainstay of treatment is with hydroxyurea or with blood transfusion. And when I see my patients, so young patients from about the age of 3, I start teaching them the 5 rules of sickle cell disease, which is take your hydroxyurea, drink water, take your hydroxyurea, and they smile at me at this point. 4, I say, is take your hydroxyurea, and what do you think 5 is? And even my 3-year-olds can say, take your hydroxyurea. So it is really important. Why do I go on about it? Well, it's because this drug is effective at reducing crises, complications, dampening inflammation, improves quality of life and life expectancy. It's safe and it's cheap. And it is the treatment of sickle cell disease. It's not an option. We try and start it really early, about 6 to 9 months of age, but it's never too late to start. And we have to maximise the dose to make sure we really push up the amount of hemoglobin F rather than S in the cells. And for an adult, that might be 4 or 5 tablets a day. I've had experience now with 150 children and teenagers here in Australia and in the Middle East when I was working in Qatar, and really pushing hydroxyurea, getting them on side, and befriending them meant that they did comply with their treatment, and they had almost no crises, and only 3 of them needed regular transfusion. So it really does work. And so I used to think I should have had this made into a fridge magnet for them. So there you are. So thank you very much. And I'll close my screen so that I can answer any questions.
There you go. Thank you, Catherine. That was actually a very good presentation.
Thank you.
The important message we got out of that was take your hydroxyurea. Very important.
Sorry about that.
No, that's fantastic. Yeah, it's a good message to have. I know that there's some patients that are not able to take hydroxyurea. Is there another option for them apart from obviously the transfusions or apheresis?
So apart from pregnancy, there are very few times in life when people can't take hydroxyurea. It's extremely rare to suffer from an allergy to this drug. It's very non-toxic. So, you know, I stress the importance of really trying hard. There are some new drugs that are coming onto the market. They'll be a little slow to get there, that we've heard about in the last few years, and all of those are compatible with hydroxyurea, so they might add even more to our treatment. But the message remains the message, I'm afraid.
Yeah, no, that's fine, and that's for those people that obviously are unable and knowing that there's other options coming to us. We also have another question from Patrick, who said that my daughter had a delayed hemolytic reaction to transfusions about 12 days after transfusion. What's the future implications if we need transfusions? She is currently on hydroxyurea.
Great, I'm glad she is, and you can make her a fridge magnet. Well, the blood bank in the hospital goes through a very detailed process in matching, cross-matching blood, and also trying to source blood that is the same type as hers, as close as possible as we can get from our donor population. So they will know that she's had this reaction in the past, and we'll be able to find blood that won't cause a similar reaction.
Okay. There was another question here. Can sickle cell trait carriers donate blood or plasma?
Blood, no. Plasma, I think yes, although I might need to take that one on notice. Blood, no, unfortunately, because of the filtering system that we use to take out the white blood cells, and they get clogged, unfortunately, with patients, even if there are only sickle tray cells there. So at the moment, no. But I don't see any reason why being an apheresis donor for plasma shouldn't be possible for anybody. Okay. And we need loads of plasma. We're still importing half the plasma we need in the country. Oh, wow. So yes, plasma, please donate.
Someone else has also asked, can you show the 5-rule slide again? And
with pleasure.
Yes. And another, I guess another question is, some have crisis even on regular hydroxyurea. What must be the reason for this?
They do, and I'm a bit naughty in not saying so. It may be that you just need to push up to an even higher dose. One of the, as people will know, we check blood counts on hydroxyurea, and to make sure we're not giving too much from the point of view of the other cells in the blood, the white blood cells and the platelets. But it can be pushed up higher than people think to really try and get that effect. But nonetheless, there are still some patients who appear to be resistant. But it is unusual, and it really is worth going back. And I don't know whether I told this story last year, but when I was working with Joe in London, I spent the afternoon with an orthopaedic surgeon who had been doing hip replacements on patients with sickle cell disease, and as you know, avascular necrosis of the hip is a very common, very painful condition, and a very common need for a hip replacement. And he said to me, you know, the patients who are on hydroxyurea, they just recover more quickly. They have so fewer complications. It seems to be fantastic. And so I like saying to my hematology colleagues, you know, by the time even the orthopedic surgeon knows it's a good drug, we ought to be pushing it. So,
okay, I have Agnes. She's got a hand up.
Hi, Agnes.
Would like to say something. Go ahead, Agnes.
Yes. Hi, Professor Cole. It's so lovely to see you again.
And you.
I just wanted to come on and let people know who are watching that this is the doctor who diagnosed my daughter about 13 years ago in Western Australia. At the time, I had no idea, and she really had to convince me, I think 2 days, explaining what sickle cell disease was. And I had to track her and just see where she is, and we reconnected early this year. I just wanted to pass a comment, Professor Cole, when you spoke about the plasma donations. You know, this is something that we actually had to have like 3 or so meetings with the head office here in Melbourne. I, being of course a carrier, we donated plasma with my husband back to back. At one time in 2016, we even had a challenge where we had created the Red Cell 25 at the time to have people donate about 120 donations. And part of that was my donations and my husband's donation. And when my daughter turned 21, she also wanted to join the family. Then, and it so happened it was my birthday, 2018. I can't forget that date. And I traveled to the city because somebody told me that, oh, your daughter's photo is in the city. I was like, it's my birthday. I want to go and donate in my honor. And then we were told, because my daughter just turned 21, that no, because of her, they said, no, you can't donate because you have a sickle cell trait. I was like, what's the difference? I've been donating for the past 11 times.
Yeah,
so
I don't know. I'm going to take this on notice and look into it, Agnes, and I shall send you an email which you can share with the group.
Yeah, it took almost 3 years to actually sit, have a conversation with Maureen Bola and Dr. Peter Daly to just explain that there's no really scientific backing, not much research is into why sickle cell trait carriers can't donate blood, but it's a case of they think it's a risk to people who have the sickle cell trait to donate, so they don't. And so we are in the process of doing a brochure with the department so that we can make it clear for people living with sickle cell trait that no, in Australia, even if you want to donate plasma, you can't. But that's something they said might change. So please take it up for us.
I will indeed, yeah. We need plasma, goodness me.
Have people who are willing, myself, Natalie, and I think a few others donated at the time, who are willing to donate. But of course, if it's a risk on our health, risk that. But we just want to have a clear understanding. And they said the rules might change. So for now, and your system is sometimes funny. They still call me and my husband, when are you donating? I have to remind them that no, this is, we're on hold for now. So please take that up with us. But we just thank the Australian Red Cross Lifeblood for what you're doing. Most of our patients depend on blood to actually survive. And my daughter, myself, she's for 10 years she was having red cell exchange, and you know the story very well. But just want to thank you on behalf of patients living with sickle cell disease. Thank you so much, Isabella.
Thank you.
Thank you. Okay, Catherine, I'm going to have to say thank you very much for presenting this. This is great information for those people out there wondering what the best approach is with blood transfusions or regular blood transfusions versus hydroxyurea. Obviously, hydroxyurea is the better option. I know that with my children who have apheresis, that some of the problems they have is waiting for blood to come in. We live here in Queensland, and sometimes it has to be transported from interstate for them to have their transfusion. So, it's very difficult, especially in these present times that we're in. So, everyone out there, encourage your families, encourage your friends to donate blood and let them know how important it actually is. It does help people live a better life because of the donations that are actually made. And I know that there is a very low donation from people from African communities. So please promote this through your communities. Let them know how important it is to donate blood for those people from those cultural groups. Thank you, Catherine.
Thank you.